Why preventive measures are so important in TLS is because you really don't want TLS to evolve. And it's a very preventable entity. It's important to recognize. So it's once you get into tumor lysis syndrome, there's really not a lot of, it becomes more difficult to reverse that process because the damage is already done. So the key is just like in almost anything, if you can prevent it, then you're not going to have the clinical manifestations. And that's the most important portion is, well, probably the most important portion is the recognition of patients at risk for tumor lysis so that you can begin preventative measures with them. We generally think about the patients who are at risk for tumor lysis syndrome as having malignancies that are very responsive to chemotherapy or have a high proliferative rate, meaning that the turnover rate among the cells is very, very high. Generally, a high proliferation rate correlates with their sensitivity to chemotherapy, but again, that's not always necessarily the case because there are certain therapies for which will have a very high response rate, but the tumor may not necessarily have a high proliferative rate. Other patients who are at risk or have large, bulky disease because the larger amount of tumor and when it starts to lyse, will have a greater amount of content and then overwhelm the body. And then there's patients who present clinically who have pre-existing conditions that make them more vulnerable, particularly patients who have pre-existing renal disease, so therefore their clearance is going to be less, or patients with pre-existing cardiac abnormalities, including arrhythmias, that are going to be more susceptible to the potential complications of tumor lysis syndrome. And then the other patients to be identified is when they present with electrolyte abnormalities, which may occur as a result of their disease. They may present septic, and therefore they're not perfusing their organs well, have low blood pressure, and then patients who are dehydrated, and again, not the perfusion of the kidneys that make them more susceptible to the potential complications of tumor lysis syndrome. There are preventive strategies, and it's multifaceted. So the keys are, again, identifications of the patient at risk, and which we've talked about previously. Hydration becomes a key element in this. And it's not only that you're hydrating the patient, you have to make sure that the patient is also producing urine. So if you keep giving tons and tons of fluid and the patient's not producing any urine, you're really defeating the purpose. And sometimes as part of that hydration process, you need to include diuretics. If a patient is urinating well on their own, then that's fine. But if you see that they're not, you need to be maybe helping them along through the administration of furosemide. And if you also see that there's low urine output, you need to be thinking about there's potential obstruction. And that obstruction could be anatomical. Maybe they have a large tumor mass in their abdomen and therefore they might need to be stented. Or there's already the formation of the uric acid crystals that we had talked about previously, or other form of crystals that can occur in the process of tumor lysis. The next portion is that you need to give agents that lower uric acid levels. And so if a patient already has high uric acid levels, you're going to be thinking about using a uric oxidase or such a drug as rasburicase to try to get those uric acid levels low or lowered. And the other, if a patient comes in with relatively normal uric acid levels, you can think about the use of allopurinol, because allopurinol prevents the conversion of xanthine into uric acid, and so is a preventive measure in that regard. And then coming back finally is the monitoring for this. And so there's multiple things that need to be monitored for, and particularly all of the electrolytes, potassium, sodium, but included in this is calcium and uric acid. And another laboratory value that's extremely important is LDH, because LDH serves as a surrogate marker for that proliferation rate that you can observe with cancer cells, particularly hematologic malignancies. And you will see a surge in the LDH during that process of tumor lysis syndrome. And you can monitor if you think that your treatment's being successful by seeing a subsequent decline in the LDH.
Regarding the preventative measures for TLS, major strategy here is to prevent even laboratory TLS from occurring. Again, laboratory TLS are numerical problems, an elevated potassium, an elevated phosphate, a decreased calcium, for example. They stay laboratory as long as they don't lead to a clinical consequence. The clinical consequences are the ones that I already mentioned, like kidney dysfunction, renal failure, cardiac arrhythmia, neurological consequences. The preventive strategies to prevent even laboratory from happening in the first place are the combination of frequent monitoring of labs, electrical monitoring of the heart, aggressive intravenous or oral fluid intake, and uric acid lowering agents. All of those things are given prior to a TLS event occurring, so to try to ensure that those don't occur in the first place. If the event does occur, like for example, an elevated potassium, we can increase fluids, we can increase monitoring, we can give drugs like sodium polystyrene, which can help lower the potassium level, for example, by minimizing the absorption of additional from the gut. So there are measures aimed at prevention and then measures aimed at treatment. If a uric acid is elevated while getting fluids in allopurinol, for example, one might give a drug like recombinant uric oxidase to lower the uric acid acutely so that that doesn't further lead to damage in the kidney, for example. TLS is an acute event, and so generally when it occurs, it's happening on the scale of minutes to hours to days, usually in patients who are either in whatever setting, academic, community, or in the inpatient setting. And so, you know, the goal of minimizing the risk is to manage them no matter where they are. If they're home, they should drink more fluids immediately and come in for additional labs. If they're in the clinical setting, they should be given IV fluids. They should be given stat measures to lower the particular electrolyte abnormalities and potentially be admitted. If it's a life-threatening event, like someone is comatose or intubated or has a life-threatening arrhythmia or requires dialysis, they may not be as easily handled in a community setting and may need to be transferred. But it's not the type of event that when it occurs, you have time to, you know, pick which hospital you want to be cared at. The best way to manage the event is to manage them immediately where they are, and then think about the acuity, the level of acuity that's needed in order to address the event fully. Usually TLS occurs in a small percentage of patients. It can occur on the scale of minutes to hours to days. Chemotherapy today, it's not going to occur 3 weeks from now. It'll occur today or tomorrow, but most of the time it's minutes to hours from the time of exposure. When you're thinking about the complications of TLS, one of the issues may be renal dysfunction. The standard of care for managing renal dysfunction is to increase renal perfusion, largely by oral or intravenous fluids. There are certain circumstances where the kidneys can't be managed by these conservative measures, either volume issues or the kidneys need to be unloaded in the setting of progression of renal failure, or electrolytes are difficult to manage with standard interventions. Thinking about IV fluids, there are certain ones that are very standard, like normal saline, and others that probably should not be used. Lactated ringers, for example, is an alkalinized fluid that contains calcium and it contains potassium. There, you may increase the risk of calcium phosphate deposition in the kidney. In addition, we're trying to keep potassium lower, so it makes no sense to infuse potassium simultaneously. Some people have used sodium bicarb added to increase the solubility of uric acid. I would argue against that as not being the standard of care, because while it might slightly increase the uric acid solubility and it's not enough to be clinically significant, that change in pH will decrease the solubility of calcium phosphate and lead to crystallization in the kidneys, which may defeat the purpose and actually make the renal function worse. So it's very important when you're taking care of these patients, particularly if they're residents who are managing the patients who may not be familiar with prophylaxis or treatment, to watch very closely what fluids are being used for patients.